Hi, my name is Hannah Bryson. I'll be answering question 3 for this HBHE presentation. I will be referencing the article Key Components in Planning, Implementing, and Monitoring a Behavior Change Communication Campaign that Increased Condom Use Among Male Clients of Sex Workers in Southern India to answer the following questions. So, to begin, which health disparities are being addressed in the condom use promotion program? The most noted health disparity was the increased risk of HIV among heterosexual male commercial sex clients belonging to a lower socioeconomic class. Another health disparity slightly touched was the lack of sex education. Now, these lower socioeconomic classes were considered classes C, D, and E, and they were based off of education levels and the head of the household's income. Now, this increased risk of HIV was considered a health disparity because 2.5 million people have HIV in India. This is 10% of the overall world's HIV cases. Below, I have provided an image that highlights the regions of southern India that were targeted in this campaign. So, are these health disparities also health inequities? If you are unsure what these two terms mean, we will be going over that more in depth in the upcoming slides. But for now, the answer is yes. The increased rate of HIV in southern India was a health concern that was significantly decreased through the programs in the condom use promotion campaign. A health inequity is considered an avoidable event. So because there was something that was done, such as the targeted programs, it decreased the health disparity. So how did they do that? They increased access to condoms, they increased consistent condom use, and they increased access to proper treatment of STIs. And they were successful. They noted that 84% of male commercial sex clients recalled seeing at least 1 out of 3 of their activities involved in their programs. And they found that there was an increase in consistent condom use when there was an increase in positive beliefs. The positive beliefs were described in the article as just basic sex education about condoms, such as condoms won't break if used correctly. This is why I added the disparity of lack of sex education. It seemed in the article that there was a lack of sex education among the men in the lower socioeconomic class that in turn resulted in the lack of condom use. When they increased the amount of condoms available and increased the information, there was an increase in condom use, which decreased HIV. So, are all health disparities also health inequities? No. The terms are sometimes used interchangeably, but they are not always the same. For example, sometimes a health disparity cannot be avoided, such as due to genetics. An example is sickle cell anemia. There is a higher risk in African Americans, but there's not much to be done about that because basically it's just genetics. But a health inequity is seen as an unavoidable or an unnecessary but avoidable event due to race or socioeconomic status. Some refer to it as a social injustice or just unfair. But you want to reduce health disparity, which brings us closer to reaching health equity. That is kind of the overall motto or slogan for the CDC about health equity. So, is there a difference between health inequities and health disparities? So here I've provided 2 definitions from Healthy People 2020. One for health equity and one for health disparity. In basic terms, a health equity is achieving the highest level of health for all people. And a health disparity is a particular type of health difference that is linked with social, economic, or environmental disadvantages that affect a group of people specifically. So to be more direct, I have provided examples here of health disparities. So the National Cancer Institute documented that African American men have a lower 5-year cancer survival rate for lung, colon, or pancreatic cancers compared to non-Hispanic white men. In regards to socioeconomic status, they found that those in lower SES classes have disproportionately higher cancer death rates than those in higher SES classes, regardless of race. The CDC reported that African Americans between the ages of 18 to 49 are 2 times as likely to die from heart disease than whites. And also, according to the CDC, more pertinent to the article involved in this discussion, there was an increased risk of HIV and STIs among individuals who exchange money for other items of sex. This statistic is similar to that we see in the increased risk of HIV in sex workers in southern India. Here I have also provided examples of health inequities. The Boston Public Health Commission stated that babies born to African American females are more likely to die their first year of life than babies born to white females. They found this to remain true regardless of socioeconomic status. They believe that there is something that can be done. They found this just to be unfair due to treatment for the babies of African American females compared to those of white females. The World Health Organization stated that children that live in the poorest 20% of households are twice as likely to die before they reach the age of 5 than those in the richest 20% of households. They believe this is due just to lack of access due to their socioeconomic status, but this could be avoidable if all people were able to attain the highest level of healthcare treatment. So here I've provided some images that better demonstrate the difference between health disparities, health equity, and health equality. The bottom picture demonstrates health disparities broken down by race. You can see heart disease and cancer remain among the top 2 for all races, but as you look closer, there are some diseases and some disorders that are more pertinent in some races compared to others. These is what we would consider a health disparity. So, reference groups for assessing the health disparities addressed in this program. Here I have provided 4 different organizations that are involved in sex education, HIV, or condom distribution. So, the National HIV/AIDS Strategy began in July 2010, recently moved to a focused group in the United States, but they are focused on the HIV epidemic nationally and in the United States, as I just stated. So the National Coalition of Sexual Health, they partner with different programs such as the AIDS Community Research and Adolescent AIDS programs to provide sex education, AIDS, and HIV information as well. The condom distribution program, similar to that of the program seen in this article, they make condoms readily available. They partner with the NYC Condom Organization as well as the DC Health and Wellness Center and the AIDS Healthcare Foundation, which recently just ran a campaign called Love Condoms Campaign to decrease STIs and HIV. And the Center for Disease Control and Prevention offers many statistics, information, and organizations that are involved in the increased research and programs and organizations that are targeted for HIV and are hoping to prevent and decrease the risk of it and the amount of it seen nationally and in certain regions such as India in the future. And here I have provided a list of the references used throughout this presentation, such as Healthy People, Cancer.gov, CDC, the Boston Public Health Commission, and the World Health Organization.